Welcome, everybody, to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Ben Thrower, who's going to answer, as usual, as many questions as he can for the next 60 minutes. So I'm delighted to introduce him. Dr. Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, and he's also, and we're very proud to say this, the Senior Medical Advisor for the Multiple Sclerosis Foundation. If you'd like to see his entire wonderful bio, it is in the registration site that you registered for, and you can always go back and see that if you just wanted to confirm every little thing. You're welcome to read it. So, Dr. Thrower, we're pleased to have you. Let me just give everybody some directions for those that haven't been here. I would hope that none of you are planning on using the chat area to put your questions tonight, because we are really, really going to try to save that area for the people that are attending through Facebook, because there is a difference, and we're going to put all of your questions into the Q&A area. So that would be so helpful to us if you were to listen to that and actually adhere to it. I'll try to remind you in between for those that are attending, not at the beginning, but come in afterwards. But it would really help us be able to organize the questions if you stay with the Q&A area. If you are one that wants to do something anonymously, it gives you that option also. And if you are signing in today using your phone, you just have to press 9 if you want to raise your hand and do a live question. Obviously, there's that app also if you want to do the live question if you're not on your phone, but rather on your computer. So I'm going to say we have questions already. Why don't we get started? Let's
Say,
see.
Deb, I don't need to share my screen. I was actually a month ahead of time.
Oh, yes, you're
So that's
right.
awesome. Very
You're
good.
right. You're right. Oh my
Way
gosh,
to
I can't
go.
believe I didn't see that. Okay, so let's go to the Q&A. Your opinion is needed on Baclofen versus Tizanidine for MS spasticity. I'm 66 and legs definitely weaker than when taking 10 milligrams of Baclofen 2 times daily. Pain and spasticity improved, cut to 5 milligrams 2 times daily and no effectiveness. Doctor said to try Tizanidine. Your thoughts?
So we can't really say that one is better than the other for spasticity and spasms. Baclofen and tizanidine are just different. It's really a matter of finding what's best for you. Um, One of the differences between the two is that with baclofen, there is the potential that we kind of overshoot and we make people feel kind of noodly and weak. So sometimes in the process of getting rid of the muscle tightness or spasticity, we end up pushing too hard and make people weaker in their legs. We don't tend to see that with tizanidine. One thing that we see with tizanidine that we don't see with baclofen is occasionally tizanidine can lower blood pressure. So if you're prone to feeling lightheaded, let's say with going from lying to sitting or sitting to standing, that's something that might be worsened with tizanidine, whereas we don't see it with baclofen. One of the rules with both of these medicines is to start with a low dose and slowly go up on the dose until either you get the effect that you want or you start running into side effects. And with both of these medications, it's really important that we never abruptly stop a maintenance dose. So if you've been on one of these drugs for, I would say, more than a week, we want to kind of slowly come down on the dose and not stop abruptly.
Thank you. And someone wrote in a question. They said last week there was a webinar with Sherry Binns where she stated that Mavenclad should not be used by people in their 40s, as after the average of 15 years of not needing a DMT, what do you do next? Is there truth in this?
So, one of the appeals to Mavenclad is you do your 2 doses with the medication, year 1 and year 2, and then in theory, hopefully you don't have to do anything else. But we only have data out to a certain time. So one of the concerns is, maybe if we use it in a younger person, someone in their 40s, what it, when we sort of go past that time that we have data, 15, 20 years, what do we do afterwards? And so hopefully we'll get more research that looks at maybe redosing with Mavenclad in the future. But I would say right now we probably tend to think of Mavenclad maybe in an older individual, not so much maybe someone in their 30s or 40s. And that's where Sherry was coming from with that comment.
She also has another question. She said, I start year 2 of Mavenclad next month. I had no side effects at all with year 1, and my lymphocytes dropped to 1.3 from 2.1. Should I expect the same or something different?
In my experience, Mavenclad tends to be a really well-tolerated drug. So, and certainly if you did well with year 1, I would bet that you will do fine with year 2 as well. So, yeah, in general, kind of how someone tolerates the first round is going to be to a certain degree predictive of how they do with the second round.
Thank you. How do you feel about low dose naltrexone for neuroinflammation? Do you feel it's effective in controlling symptoms?
So low-dose naltrexone, you got a lot of attention years ago. It was kind of an internet phenomenon. So low-dose naltrexone, in theory, increases your body's natural endorphins by partially blocking some of these natural opioid receptors in our body. What research has shown is it's clearly not a true disease modifying therapy. I wouldn't look at it as something that would prevent relapses or slow progression of disability or prevent new lesions on MRI. What research has suggested is that maybe quality of life tends to improve slightly. Emphasis on slightly. I think it's an incredibly safe thing to do. We have patients who take the 3 milligrams, 4.5 milligrams, and I don't think I've ever seen significant side effects from it. What tended to improve in some of the studies were things like fatigue or pain management. And again, it was subtle. It wasn't a blockbuster drug. But if we have someone who wants to try it, I'm certainly not opposed to it. And it's usually an expense out of pocket because it's a compounded off-label use of a medicine. So it's probably going to be something you pay for out of pocket. Not a tremendously expensive drug, though.
Thanks. Trey's asking, what's the best exercises to do at home or gym for leg strength? And also, he says he has foot drop, but he does have strength in his leg, just needs to build it up. What's
Yeah.
the best way?
So on the first part of that, and we'll come back to the foot drop. So we sort of halfway jokingly say the best exercise for any goal you have in MS is the one that you're going to stick with and that you have access to. So if we, have you doing some sort of exercise that you just don't find very enjoyable or it's difficult to access it, you're probably not going to stick with it. So, with exercises, it's the I think getting in with, if you can get with a physical therapist or an exercise physiologist who has experience with MS, they can help you design an exercise program to meet your goals, whether it's something at home. One of there are a lot of websites where you can go for home-based MS exercises. Can do MS, if you just Google that phrase, can do MS is a great source. They're free. They have a wonderful library of home-based videos for you to help meet any of your goals. Foot drop is something that I could talk for hours about because I think it's an under-recognized symptom in MS, and it really impacts people's ability to walk. So, when you're starting to drag that foot, there are all kinds of bad things that happen. You circumduct your leg, you put stress on your knee and your hip and your lower back, you fatigue quickly, you're at risk for falling. So I really encourage people, if you've got foot drop, get in with a physical therapist. We have all kinds of things that we can do to improve that. And it's just simply not something you have to put up with.
Thank you. And Stephanie's asking, what alternative DMT should I consider if my new insurance does not approve the Kesimpta I've been taking?
So, I would say if you're on Kesimpta and your insurance is denying it, I would certainly have your healthcare team maybe try to at least appeal that and make the argument that you've done well with it and fight for it. If they're just simply denying it, one other option would be to go through the Novartis financial assistance program and see if the pharmaceutical manufacturer might cover it for you. If that fails, then there are other B cell therapies out there. So the other things in that class that work in a similar fashion immunologically would be Ocrevus, Briumvi, and all of the different versions of rituximab. So if you just can't get your insurance company to budge, if you can't get financial assistance, you certainly can look at one of those drugs, and they are equally effective to Kesimpta.
Thank you. Any thoughts or experience with, I think it's Gemtesa?
So, Jim, when we think about bladder symptoms with MS, the class of drugs we've used for a long time are called anticholinergic drugs. So these are your oxybutynin, Detrol type drugs. The newer drugs have a different mechanism of action. So this would be Gemtesa and Myrbetriq. They work on different chemical pathways. The advantage to Gemtesa and Myrbetriq over the older drugs is they don't tend to have the dry mouth and constipation that you can see with the other drugs. I think in a perfect world, we probably would use Gemtesa or Myrbetriq as our first choice for managing overactive bladder symptoms. You be aware that because they tend to be a little pricier, a lot of insurance companies are going to want you to try one of those older drugs first. In fairness, the older drugs, like Detrol and oxybutynin, do work fine for a lot of people, and some people find one of those older drugs that doesn't cause a lot of side effects. So yeah, the Gemtesa and Myrbetriq, great drugs, great for overactive bladder symptoms, but you may have to try one of the older ones first.
Thank you. And David has a question that he wants to ask you himself. So David, go ahead and unmute yourself.
Hello, Dr. Thrower.
Hi, David.
I have been living with MS for 28 years from the age of 14. But now I have found that there's some stem cell patches. My question to you, does the stem cell patches work for multiple sclerosis? And if so, like, how is it going?
So was that stem cell you were saying?
Yeah, stem cell patches. I researched it. It came out in 2013.
So just for the rest of the audience, so when we talk about stem cells, there's sometimes we need to clarify what type of stem cells we're talking about. So there's hematopoietic stem cell transplantation. So that's the idea of using your own immature bone marrow stem cells to basically reboot your immune system. So that with that procedure, you would receive some sort of immune ablation or chemotherapy procedure to wipe out your existing immune system, and then you'd be given your own stem cell, immature cells back intravenously to reboot a fresh, clean immune system. There's a lot of data out there on that. In the right patient or individual, that can be very effective. Obviously, there's some risk associated with it. Here in the US, it's not FDA approved yet, so if you would have to do it through a study. I really do think it will get approval in most countries around the world. And then the other type of stem cells where there's a lot of interest, it would be sort of the neural repair type of stem cells, cells that hopefully would help regenerate fresh myelin or axons and reverse disability. A lot of research going on around the world with that type of stem cell. I would just say people need to be a little cautious about the private stem cell clinics, where you can go and pay, usually a large sum of money, and they'll give you some type of mesenchymal stem cell. Those are just really a case of buyer beware, because we don't know where those cells are coming from necessarily. There is a lot of legitimate mesenchymal stem cell research going on. What's interesting with mesenchymal stem cells is, if you had asked us years ago, the thought was maybe they have to get into the brain and spinal cord to repair damage. That may not be true. They may actually be secreting neural sort of repair, sort of chemicals, if you will, that could be secreted outside of the brain and spinal cord. That those chemicals are what are actually crossing the blood-brain barrier and promoting repair. So I'd say stay tuned. It's certainly not quite ready for prime time yet, but very promising.
But I understand what you say, but So the patches, you talked about the real stem cells, which
Oh, the
is really,
patches.
but the patches, is that, are they good to use or
I
just leave them alone?
I would say not quite ready yet. The idea of getting stem cells across the skin in a patch, I would be very dubious about that. Yeah, I would say until there's more data showing some more definite efficacy, I would be very cautious about spending your money on that.
Okay, David.
Thanks,
I
David.
hope you got your answer. Thank you. Okay, let's see. Okay, so Stephanie, let's see. Stephanie asks, which medications help patients like myself with smoldering MS?
So the concept of smoldering MS has kind of been a hot topic over the past, I'd say 3 years or so. So the idea with smoldering MS is that if MS, is a forest fire, and maybe with normal human aging or with a disease modifying therapy, we put out that big fire. Well, maybe there's still something going on under the surface. Maybe they're just these smoldering embers, if you will, driving progression of disability. So the way we think smoldering MS would look in the exam room would be the person comes in and says, my MRI is stable. I'm not having relapses, but I still feel like I'm getting slowly worse. We think smoldering MS might be driven by a type of cell in the central nervous system called microglial cells. We were excited late last year when study results for a drug called tolobrutinib came out. They looked at tolobrutinib across a large variety of types of MS. Where it seemed to shine, it was in secondary progressive MS without activity, which is the person who's just slowly getting worse, which we would think may in part or in whole be due to smoldering MS. It is anticipated that that drug may get FDA approval around September of this year. Um, what the study showed is that there was a slowing of progression of disability by about 30% at the 6 month mark. I think at face value, you might say, well, 30% slowing, and I wish it was better than that. But the fact that it did it at 6 months is pretty impressive. None of our other therapies have really worked very well in that form of MS. So it does give us some hope. We'll want to see, obviously, all of the data. We'll want to see what it looks like from a safety standpoint. In the study, they did liver function blood testing every week for 6 months. We don't know if that's what the FDA would require in the real world if it gets approval, and what does that look like logistically. So we'll be excited to see what happens around September of this year.
Okay. Thank you. Also, I know, Bobby, you just put a note in, but I'd like to tell everybody to please, again, keep all your questions coming in through the Q&A area, not the chat. So it'll be much easier to navigate those. So can hyperinflated lungs be a symptom of progressive MS, doctor?
So typically not. MS can cause some respiratory symptoms, but the most common thing that we would see is actually called a restrictive ventilatory defect. It's not really a direct lung issue. It's more the muscles around the rib cage, if you will. Most of what moves air in and out of our lungs would be the diaphragm, the big muscles under the lungs, but the muscles in between the ribs do contribute some. And so if you have weakness or tightness in those muscles, people with MS can get a very distinct sense of shortness of breath. The good news is that the actual oxygenation as measured in a pulse oximeter is not affected, but it's distressing to people. One of the things that therapists work with in people with MS that might be having pulmonary symptoms is using something called a breather. This is usually done through a speech language pathologist, and it's a device that you sort of breathe in and out of, and you can change the resistance for both inspiration and expiration to help strengthen and maybe stretch some of those muscles. whenever someone with MS is describing any sort of respiratory symptoms, we want to make sure that there's not a non-MS explanation for those symptoms. We don't want to automatically go to MS as the culprit for everything. We want to make sure there's no other, cardiopulmonary reason why we might be dealing with shortness of breath.
Thank you. And this is a little vague, but Anne would like to know what your thoughts are about a 67-year-old woman who has been diagnosed for 36 years.
Well, I hope she's a 67-year-old woman who's doing well with her MS. I mean, we deal with MS across the whole age spectrum, from pediatric patients to individuals who are in their 80s and 90s. The good news is that as we age, our immune systems do tend to quiet. The concept is called immune senescence. So a lot of research and focus in the past few years on maybe taking people off of disease modifying therapies as we get older, because maybe the need is just not as there. So it's maybe people are able to take a break from their medicines. Sometimes that lets us shift the focus more to just symptom management and quality of life, and making sure that the person is really staying as fit and strong as possible.
Thank you. And Tricia says that she's just wondering what you might know about these new weight loss drugs linked to lowering rate of MS.
So I haven't seen any hard data for the GLP-1 drugs, your Ozempics and Wegovys, Manjoros. Clearly, we have a lot of individuals with MS who are on these drugs, and there's no reason a person with MS can't be on one of these drugs if it's indicated for weight loss or control of diabetes. There is some evidence that they may be anti-inflammatory, so I think there's interest to see, do these drugs have a positive effect in autoimmune conditions, or do they lower the risk of MS? I would be a little surprised, and this is just me speaking theoretically, I'd be surprised if they lowered the risk of MS, because really, if you think about a person's risk for MS, we think you've got the genetic component, which you're born with, and then the environmental component, much of which we think, all of that environmental component probably takes place before the age of 15 or so. So, putting maybe a 35-year-old person on a GLP-1 drug for weight loss or diabetes control, I'd be surprised if it lowered their risk of MS.
Teresa's asking, how can she better cope with the extreme pain and immobility caused by the stress of these California wildfires that are life-changing beyond imagination?
Yeah, I mean, our hearts go out, obviously, anyone who's affected by that, or if you have loved ones or friends who are affected by those wildfires, and we all pray that they're out soon, and that people are able to rebuild. Stress doesn't always play well with MS. I think if you ask most people on the line, do you have symptoms that worsen with stress? Most people would say yes. When you think about stress, you throw in sleep deprivation and all of those things. I know there are counseling services that are available to people who are being affected by those wildfires. I would take advantage, of any of those, even if it's online, just to have someone to talk through, to give you some resources to deal with the real, the things, whether it's loss of your home or property, or needing to evacuate, which can be stressful. The good news, if there's a silver lining to thinking about stress and MS, is it tends to be a worsening of symptoms, not a true worsening of the progression of the illness itself. So, I don't think that most people under stress are at higher risk for true relapses or progression of disability. Usually it's going to be a temporary worsening of symptoms.
What DMT options do you start looking for or looking at for patients who have already gone through all the major mechanisms of action for MS, DMTs? Are there off-label drugs, such as, I guess, drugs usually used for rheumatoid arthritis, that you would consider? Is that when you would go for clinical trials, or just go back to the MS DMTs they had
Yeah.
the fewest problems with?
So I think if you've really been through, all the classes of drugs, you think about the B cell depleting agents and natalizumab and Mavenclad and all of and even maybe the old platform therapies, your interferons and glutamators, those types of drugs. Um, you know, we certainly have used things like Cellcept or methotrexate, cyclophosphamide. These would be off-label medications. An off-label drug that I think that's appealing to me is IV immune globulin. So IV immune globulin is given on a once a month basis. There is data out there to show effectiveness. It's well tolerated. The biggest challenge we have with immune globulin is getting an insurance company to pay for it. It is a very expensive drug. There are no financial assistance programs through the manufacturers. But if you truly have failed every class of FDA approved therapy, I think immune globulin would be something that I would look at and make the argument to your insurance carrier that you're running short on options. Clinical trials are always something to think about as well. Talk to your healthcare team. You can search clinicaltrials.gov for any studies that might be accessible and to you or that you're a candidate for as well.
Dr. Thrower, in your opinion, Karen's asking, in your practice, are you lowering the dosage or timing of the dosage on the B cell therapies in your older patients, 65 plus?
Yes, and I think we started thinking about this probably with the Delta surge of the COVID pandemic. We were trying to find that happy balance between, giving people good MS control without, significant immune suppression and putting them at risk for severe COVID infections. There is data out there with Rituxan or rituximab looking at a half dose of that drug. And this was done at some of the MS centers in Europe. And they did it as initial therapy. So these were individuals who were randomized to either full dose or half dose and watched over 2 years with relapsing remitting MS. And there really was not a difference in the effectiveness between half and full dose. The half dose group did have a lower risk of infections. As we get older, and again, because our immune systems have this natural sort of quieting, if you will, I think it is appealing to think about, lowering the dose and maybe even getting to the point where the person doesn't need to be on a disease modifying therapy at all. There is also interest in potentially extending the interval. So there was a study with Ocrevus that looked at 9-month dosing versus 6-month dosing, and there really was not a significant drop off in the effectiveness with 9-month dosing. There's also this thought, I don't think it's settled yet in the science, but maybe the B cell therapies are not just working by suppressing those inflammatory B cells. Maybe they're actually reprogramming the B cells. And so that when the B cells come back, maybe they're in a less inflammatory state. And that may be an important part of the mechanism of the B cell therapies. And if that's the case, maybe we can spread the dosing interval out on these medications. I think the important thing to just realize is everyone's different. And so, the dose and the interval that one person might need may be very different from someone else. And as we get older, maybe we do need to think about, sort of customizing the routine to that individual.
And whoops. Yep, marijuana is now legal in Michigan. Is there a type, method, or strength that you'd recommend?
So I think what we really want people to think of is cannabis. If you're using it to treat an MS symptom, use it as a medication. Ideally, you'd like to know how many milligrams of THC am I getting. It's a lot easier to do that if you're on an edible form or an oral oil form. It gets a little trickier if you're on an inhaled form of the THC. A lot of the differences between the different strains of cannabis have to do with the CBD THC ratios. So you'd like to think about that. In general, if I know how many milligrams of THC is someone's getting, if they're starting from scratch, I usually have people start with about 5 milligrams of THC orally. Again, hard to know if it's inhaled, how much someone's getting, and see how they respond to that. So, if you're treating spasms, for instance, or neuropathic pain, take 5 milligrams. Do it in a controlled setting. You're at home. You're not going to be driving. You're not going out and about. Hopefully someone's with you there if possible, just in case you had any kind of negative, sort of psychological effect with it. If you don't see benefit with 5 milligrams, I would not take anything else that day. I would wait until the next day and then maybe try increasing the dose a little bit, maybe 7.5 milligrams. Just like we do with other symptomatic medicines, you're going to sort of go up on the dose until you either get the desired benefit or you start running into side effects.
Thank you. Do you think the tau patch, and I think I'm pronouncing it correctly, is something worth the money for foot drop?
I don't. I'm just not a believer. I mean, we want to be open to any new therapies or alternative therapies, but I have just not been impressed with what we've seen with the tau patch in individuals. Again, I think if you're dealing with foot drop, your best course to get management of that is to get in with a physical therapist who's familiar, working with MS, and you look at the range of options out there, whether it's the good old fashioned ankle foot orthotic or some of the new cool devices, the Biomarkers device, the neural sleeve device. There's some nice over-the-counter devices. We really like the Saebo, Saebo step device. It's about $170 online. You don't need a prescription. Great for working with foot drop.
Thank you. Melissa's asking if she said that she's received an AFO brace from a patient yesterday, seems to make a drastic difference. Am I being too optimistic? Is that possible?
No, I mean, AFOs have been around for a long time. They're tried and true. So they come in different versions. So there's a traditional AFO that's just an L-shaped brace. It's going to keep you from dropping your foot. There are some articulated devices that actually move at the ankle, so they give you a little bit of range of motion, but they have a tension in that hinge that's going to bring the foot back up for you. There's some lighter weight devices called toe-off devices. So all of these can be appropriate. The reason I keep coming back to the physical therapist is most physical therapists have these things in the physical therapy suite, so that a lot of these they can let you try these things out so you see really what works best for you.
Yeah, it's smart. Smart, smart. Um, what factors would you consider in moving someone from oral baclofen to a baclofen pump?
Yeah. So if you can tolerate oral baclofen and you get to a dose that is not causing significant side effects and it's working for you, we're perfectly fine sticking with oral baclofen. The challenge with oral baclofen is so when we put baclofen in our mouth, it's absorbed through the GI tract. A certain amount of it goes to the liver and it's metabolized, and you don't get any benefit from it at all. A certain amount crosses into the brain. That is not where we want baclofen working. Baclofen in the brain itself is where we get the sedation or drowsiness from it. Ideally, we want baclofen working at the spinal cord level. So if you do intrathecal baclofen or a baclofen pump, you're getting rid of that liver metabolism. You can get away with a much smaller dose because you're putting it right where it needs to be. It tends to not get into the brain at the higher levels that you do with an oral dose. So sedation is less of an issue with a baclofen pump. So I would say if you just can't get the results you want with oral baclofen, maybe you've tried oral tizanidine, then that's where we start thinking about the baclofen pump or intrathecal baclofen.
And have you witnessed anyone declining while on Ampyra?
So realize what Ampyra or dalfampridine is supposed to do. I would also throw the old compounded 4-aminopyridine. So these are all really the same goal with all of these medicines. The goal is that you're improving electrical conduction in a demyelinated nerve fiber, and hopefully getting rid of nerve fiber fatigue. So what nerve fiber fatigue looks like is, I'm walking or I'm doing an activity, and the longer I do it, the more I poop out and I fatigue with it. So if you work on potassium channels on that naked nerve fiber, that demyelinated nerve fiber, with dalfampridine or Ampyra, you may improve your strength and endurance. So these are not disease modifying therapies. We don't expect this to slow progression of disability. We expect you to have better function right now by improving that nerve conduction. The trick with Ampyra or dalfampridine is it's either going to work or it's not. It's usually an all or none phenomenon, and the chances that it's going to work in a given individual are about 40%. And you're going to know within about 2 weeks if you're in the good 40% that it works for, or if you're in the 60% that it just doesn't work for. So it's really not that that you were expecting you to stop progression. It's either just going to improve your endurance and strength, or it's not.
Right. And Anne actually wrote back. She said she did a little too quickly, but she was the 67-year-old who was diagnosed 36 years ago. She just wanted you to know that she's currently on Ocrevus.
So
So,
yeah,
okay.
so with Ocrevus in a 67-year-old, we do start having that discussion, about either spreading the interval out, lowering the dose, or coming off altogether. But at the end of the day, it really is a shared decision between the healthcare team and the individual living with MS. Obviously, if the person's having side effects, a lot of infections, that may factor into the kind of the risk benefit ratio. But at the end of the day, we have individuals who they're stable on the Ocrevus, and maybe they're 75 years old, and they just don't feel comfortable coming off of it. And if they're not having side effects and it's not bankrupting them financially, I'm certainly not going to tell that person you have to come off of the drug. Ultimately, it's I look at our role as healthcare providers as kind of guidance counselors. We want you to know what we know and have you make an informed decision. We may tell you we think you're really making a bad decision, but ultimately it is your decision.
Right. And there's people who may not have heard your discussion before, but as we always get several questions about when should we stop, Richard's asking, when are you considered to not use DMTs? And I know yeah.
Yeah, so some of the studies have gone as young as 55. And so I would say before we started having, research looking at this, we probably started having the discussion at somewhere between age 60 and 65. But again, there's some data out there at age 55 now.
Okay. In your practice, are you lowering the dosage or timing of dosage on B cell therapies in older patients 65 plus? For instance, might the meds work as well at a lower dosage?
Yeah, the thing we talked about this a second ago.
Oh,
Yes.
that was the question I already read. Sorry.
Yeah, I would say, and I'm guessing a little bit, but I would say probably 40% of my ocrelizumab patients are on 300 milligrams rather than 600 milligrams, and probably the same percentage on rituximab or on 500 milligrams versus the usual 1,000 milligrams. It's a little trickier with Briumvi. That's our newer drug out there, just because we've not started playing with the dose on that, but that same logic would apply. I think the challenging one for changing the dose would be Kesimpta, just because it's the pen. I don't think we can lower the dose. We certainly could spread the interval out on that one, but I don't think we could necessarily lower the dose with each individual injection.
Thank you. I'm going to make a comment to Richard, who left a message in our chat. He's asking if any of us remember what you said about bladder control. And rather than go back there, I'm going to suggest to Richard that once we put this entire video up on YouTube, which will be in a week or two, you can watch the whole thing over and over again to grab all the information. So that's a great way to be able to see everything again and really absorb it.
And I think next month we're doing the whole thing on bladder control.
We are.
Yeah.
Good point. So let's see. What are your thoughts about switching from Ocrevus versus my current DMT ABD switching to Mavenclad for a 67-year-old woman. What are your feelings about a person over the age of 65 having contrast when they have an MRI?
So the MRI part, for us, and I think this is true for a lot of MS centers, we're doing the overwhelming majority of our MRIs without contrast now. As MRI technology has advanced, we're finding that we really are seeing most of what we need to see without contrast. So I think when you look at a newly diagnosed individual, we would probably tend to do contrast in that individual just to kind of establish a baseline. But as time goes on, the need for contrast, in my opinion, becomes much less. Tell me the first part of that question again.
What are your thoughts about switching from Ocrevus versus my current DMT ABD, switching to Mavenclad for a
A lot of
67-year-old
people
woman?
think of Mavenclad in exactly that situation as kind of an exit strategy. So you have an individual who's maybe over the age of 60. They've been on natalizumab, Ocrevus, something like that, and maybe use the Mavenclad as okay, I'm going to give you the 2 years worth, and then you never have to do another therapy forever. So I think that's a perfectly appropriate area to think about Mavenclad for.
Okay, good. And forgive me, my memory is terrible. Did I just ask you about the limbs and the numbness and pain? I
No.
don't think so. Good. So if you have tingling, numbness, pain, burning in all four of your limbs, does that mean you could someday lose the use of all of them?
Not necessarily. So pain is very common in the MS, and one of the ways that pain manifests is with what we call dysesthesias or neuropathic pain. So that burning, tingling, hypersensitivity to touch is all in that realm of what we call neuropathic pain. So that's a sensory symptom. We think of that as likely it's old demyelination, not new demyelination. And it really doesn't predict that you're going to have motor problems in the future. It probably is coming from a spinal cord lesion if you have it in all four extremities, but it doesn't necessarily mean that you're going to have motor or weakness issues in those extremities.
Thank you. How common are the impacts of vagus nerve degeneration due to the MS pulmonary, GI, and cardio impacts? What can be done to minimize or support this? And do you have any opinions of utilizing PEMF, such as the Vibe, to soothe symptoms? That's a lot.
So, a lot of people with MS have GI symptoms. We talked a little bit about the pulmonary symptoms, which tend to be the restrictive ventilatory defect. I don't know that the pulmonary symptoms in MS are necessarily driven by dysfunction in the vagus nerve. GI symptoms certainly could be. Vagus nerve does a lot of things in the human body. We can see delayed gastric emptying in people with MS, certainly constipation, really a big problem in people with MS. There are, I think there are treatment strategies for all of those things. We tend to use, number one, for bowel GI symptoms, we do recommend that people, if it's significant, maybe touch bases with a gastroenterologist just to rule out other things. Crohn's disease, ulcerative colitis, irritable bowel syndrome. Make sure there's not something else going on that would be managed to that gastroenterologist. A lot of MS centers have bowel and bladder teams, so it's a comprehensive group, maybe occupational therapists, urologists, gastroenterologists that are going to help people navigate those symptoms. Some of the devices that she mentioned are sort of external devices that maybe help modulate some of these symptoms. I think they're very low risk. I'm not familiar with the pricing on those, but I certainly wouldn't discourage someone from using some of the devices that are out there to try to help with those GI symptoms.
Great. Okay. So I'm a 62-year-old female, was diagnosed 2.5 years ago with PPMS, symptoms for 2 years prior to being diagnosed. My next door neighbor, 64-year-old male, was recently diagnosed with the same thing. Are there environmental factors that could be at play with this coincidence?
Um, clearly, when we think about someone developing MS, there are both genetic and environmental factors. We think those environmental factors, though, are things that probably happen many, many years before the actual diagnosis of MS. And some research would suggest even before the age of 15 or so. So things like low vitamin D levels, common viral exposures, a lot of research focusing on Epstein-Barr virus and the timing of exposure to the Epstein-Barr virus. So whenever we see a little sort of, if you will, sort of epidemics of MS in areas, it does prompt, researchers to go in and say, okay, was there something environmental? Two people, I think wouldn't necessarily be an epidemic. It's certainly odd, but primary progressive MS does tend to start later in life. It is, in many ways, it doesn't play by the same rules as relapse and remitting MS. It's the least common form of MS, accounting for somewhere between 5 and 10% of newly diagnosed individuals. And it does tend to be a little sneakier, so it presents a little more slowly, usually with gait walking issues. So I would think it's probably coincidental that the two people develop this in the neighborhood, but otherwise, I mean, that is the age where we tend to see it pop up in older individuals.
Hmm, interesting. Monica said her daughter and she both have MS, which is rare. Are there ongoing studies determining any correlation? Understands there is none, but just struggle to understand why.
So it's not as rare as you would think. So if a person with MS looks at their family, so what is the likelihood that they can find a family member with MS? It's about 10%. So 1 in 10 people with MS can find a family member. It's actually more common for them to be able to find family members with other autoimmune conditions. So, so maybe, this person has MS and they've got an aunt who has rheumatoid arthritis, and over here there's a psoriasis, and over here there's a lupus. So we think the genetics for MS are very similar to the genetics for other autoimmune conditions. One of the other ways of thinking about the genetics is if mom or dad has MS, each child has about a 2.5 to 3% chance of having MS. So there is a genetic component. So I would say if you go to most MS centers in the United States, we clearly have, parent-child, sort of pairs where we start worrying a little bit is when we see lots of family members. So there are some neurological conditions that can mimic MS that are strongly hereditary. So there's a condition called CADASIL, or CADASIL. It's actually a vascular condition, a stroke condition that is what we call autosomal dominant. So autosomal dominant conditions, if mom or dad has it, each child has a 50% chance of having this. So there's very strongly hereditary, and there is genetic testing for that condition. Always a lot of research going on to the genetics of MS, because we hope by studying the genetics, if we understand the genes that put people at risk for MS, well, the next question is, well, what do those genes do? And if we can figure out what that gene does and why it's acting up, can we correct that end result of what's lacking or overactive or underactive in the immune system in that person with MS?
Thank goodness for scientists, right?
Yeah, genetics is just
Really?
fascinating. Yeah.
Yeah. So there's quite a bit of information out recently about danger in taking pain meds, particularly gabapentin for nerve pain. What is your thought about that?
Everything is a risk benefit ratio, and so there there's a lot of research looking at long-term effects, cognitive effects, brain volume effects of different medications. I just don't know. Gabapentin has been just a staple for managing neuropathic pain in a lot of different health conditions. I think if we can find non-pharmaceutical ways or alternatives, I don't know that gabapentin is ever going away, though. I mean, we've been using gabapentin for forever, and I don't think it's a high risk. Again, if I can find an alternative, but when you think about pregabalin or Lyrica or antidepressants, they're used for pain management like duloxetine. I just think nothing ultimately is pain free. I mean, I think cannabis does play a role in pain management. We don't know of any long-term health effects from cannabis use. So, if you're in a position where you could think about, cannabis for pain management, maybe that's an alternative. We did a poster here at Shepherd in working with one of our cannabis suppliers, looking at the MS individuals using cannabis and how they were able to get off of prescription pain medicines. And what we found is that on average, they were able to reduce their dose of gabapentin or any of the other pain medicines by about 50% when they were using a cannabis product.
Wow. Would you suggest using blood biomarkers to track someone who is cutting back on their B cell therapy, or just use MRIs?
I think both. I mean, now so there are a lot of markers that are out there. The one that I think has the most data behind it would probably be neurofilament light chain, and that's pretty easily available now. So we are using neurofilament light chain in exactly that setting. So someone's thinking about going off of treatment, so we get a baseline neurofilament light chain. Chances are it's probably going to be in the normal range, and there are normative data depending upon age. Sherry Benz was kind enough recently to share that with a lot of us. So your first blood draw for neurofilament light chain probably isn't going to have a whole lot of meaning. It's when you follow it over time that it starts taking on some meaning and looking for any concerning trends. We're getting better with MRI technology. So now with MRI, a lot of MS centers are doing more than just saying, do you have a new lesion or an enlarging lesion? We're doing actual volumetric quantitative studies. So this is a good use of artificial intelligence. We want to be careful with AI, just turning it loose randomly, but where AI tends to shine in medicine is with imaging. So, we look for things like slowly enlarging lesions, which might be an indication of that smoldering inflammation, to really, do things that the naked human eye can't appreciate on MRI. Putting that together with things like the biomarkers like neurofilament light chain.
Hmm. Can you talk about the psionic sleeve?
So the psionic neural sleeve is one of our electrical devices for managing foot drop. We always welcome more options out there. So the two that we see used most commonly would be either the Bioness device or the neural sleeve. We're a little bit biased towards the Bioness device, and it's simply because we can have the individual with MS try it through a physical therapist before they ever commit to trying to get insurance to pay for it or paying for it through some other mechanism. These are not inexpensive devices. So with the Bioness device, you can kind of try it before you buy it. With the neural sleeve, because it's custom fit to the individual's leg, it's not like we can take one off the shelf and say, here, try this. It's custom made to that individual. So you do have to kind of buy it before you try it, but they have a payment system on a monthly basis. So if someone tries that device out and it just isn't working out for them, they can stop the payments and send it back. So it's definitely a good device for foot drop.
Thank you. What are your thoughts on JC virus positive patients that are staying on Tysabri past the 2-year mark? Are the PML risks too high at that point? And do you increase monitoring, or what are your thoughts on the risk benefit ratio at that point?
So it really isn't just a matter of whether the person is JC virus positive or negative. You want to know what the number is. So the JC virus antibody index. So the way the JC virus antibody index is set up, but so below 0.2 is negative. Between 0.2 and 0.4, you're indeterminate. And to say that someone's really positive, it's above 0.4, but that's not the important number. What data has shown, and this data has been collected over many, many years, the really important number is 0.9. So you have a group of individuals between 0.4 and 0.9 who are technically positive. Their risk really isn't any different than the JC virus antibody negative person. So it's when that number starts crossing 0.9 that we start having more concern. So the 2-year that 2-year time point really was more important either when we didn't have JC virus testing at all, or when we only had the positive or negative. Now that we have the index value, I'm not so much concerned about the 2-year mark. If we have an individual who has been on Tysabri for probably well over 20 years. He was in studies. I mean, he's been on it for a long time. Um, and his JC virus antibody index has stayed, at that 0.2 range. The other area of a lot of research is, so what if you do have someone who's above 0.9 and you feel like they're in a higher risk group? So there is research looking at extended interval dosing. So rather than doing every 4-week dosing, doing every 6-week dosing. And what we know is that moving that interval out to 6 weeks does lower the risk very dramatically. It's not zero, but it is dramatically less. This is definitely a situation where it's a shared decision. So the healthcare team talking to the individual, thinking about, how well have you done with Tysabri or natalizumab? What are your other options, and what's an acceptable risk to you? So we do JC virus antibody index testing. We're a little obsessive. We do every 3 months in everybody. The FDA recommendation is 6 months. If your JC virus antibody index is starting to creep up a little bit, and maybe it's approaching that 0.9 range, we'll start doing monthly testing.
Thank you. Okay. 30 years of MS and over 65 now have active secondary progressive MS. The last MRI showed 2 cervical spine lesions. Any opinion on possible DMTs that she should try, or he?
So I think, so we make this distinction between relapsing remitting MS and secondary progressive MS with activity. And when we say with activity, we mean either the person's having ongoing relapses or new lesions on MRI, or both. I don't make a distinction in treatment options between those two forms. I think anything I consider active secondary progressive MS to be a relapsing form of MS. And anything we would put on the table for a relapsing remitting patient is on the table for that individual. Every MS center out there has their own bias and things that they like better. We are biased, and I think a lot of MS centers are biased towards more highly effective therapies. And so if you said, well, what's at the top of the food chain in terms of highly effective therapies? Well, it's going to be your B-cell therapies, natalizumab, Tysabri, and Mavenclad. I would say your S1P receptor drugs, your Gilenya, Zeposia medicines are going to be just right below that. And then kind of it's everything else after that. So my bias would be towards getting that person on a highly effective therapy.
Thank you. And I know you mentioned this before, but this person's asking, is the PONS device actually worth it?
I don't, it really comes down to, ideally you'd like to try it. If let's say that it was, if you look at the expense of it, but it works really well for you, well, then it's probably worth it for you. I mean, if there was a way you could try that out, and if it didn't work out, return it and get your money back, that would be the ideal situation to me. Yeah.
Me too. Anything new or any updates on new meds for myelin regrowth?
So tons of research out there. And so there's all the mesenchymal stem cell research. There's a lot of research on small molecules, usually things taken by mouth that may have remyelination potential. We have 3 studies that we're doing here. And this, MS centers around the country are doing tons of research. We talked a little bit about the vagus nerve earlier with symptom management. There are vagal nerve stimulators out there. So these are like surgically implanted electrical devices, like a little pacemaker that send a signal through the vagus nerve up to the brain. These are used for refractory forms of epilepsy. There's some evidence now that they may actually play a role in remyelination. So one of the companies that makes a vagal nerve stimulator has been given a little bit of sort of fast tracking through the FDA to move this research more quickly. So I think we'll see some studies fairly soon looking at vagal nerve stimulators as a remyelination potential. When we think about repair in the brain and spinal cord, I would put neuroplasticity in there as well. So if we can't repair it, what if we could just reroute it? At the end of the day, what we want is is to restore function. And if we restore function through neuroplasticity, I'll take that. The person's still getting better. So we do have the PONS device, the PONS device that we mentioned that's out there, that is FDA approved to potentially improve function. The challenge we've had with this PONS device is it is very expensive. I mean, it's about $22,000, and it requires a lot of working with a physical therapist to get the benefits from it. To date, I have had zero luck getting an insurance company to pay for that device. We were part of a study here, and the beauty of the study is we had the device provided free of charge to the patients. But once that study was over, now we're back to just struggling with insurance companies. And it's a pretty rare individual that can afford $23,000, $22,000 out of pocket.
Mm. I joined, let's see, have never been on a DMT. I have weak legs and weak foot muscles. I'm 72 years old. Can I go on Mavenclad?
Certainly, if there's no reason that the person couldn't go on Mavenclad, and that is kind of the I would say in the older individuals, that's who we think Mavenclad might be an ideal fit for. But I would certainly, and this is my bias because I work at a rehab hospital. Anytime we hear weakness, make sure you've worked with a good rehab team, the physical therapy team. In terms of improving your quality of life and functioning right now, I mean, we're more likely to get that, with the rehabilitation. Mavenclad really is more your insurance policy for the future to keep it from getting any worse. But yeah, think about that rehabilitation also.
Okay, we're going to make this our last question. I stopped Tecfidera a few years ago because my platelets were low. My MRIs are stable, but my disability increases. My neurologist wants to start Ocrevus. If my disease is stable, will it help my symptoms?
So again, with any of your DMTs, you be cautious thinking about them helping your symptoms. Really, any disease-modifying therapy, regardless of what it is, your real goal is something called NEDA, N-E-D-A, no evidence of disease activity, no relapse, no progression of disability, no new MRI lesions. Some people do get better on DMTs. We're thrilled for those individuals, but I think that's kind of icing on the cake when that happens. It is more likely that you would see improvement in function with more highly effective therapies like a B-cell therapy like Ocrevus or a natalizumab. So it is possible that you could do it, but we really want people to have realistic expectations. If you're seeing progression of disability, and you clearly aren't meeting NEDA, N-E-D-A. So I think that discussion is certainly worth having about starting a disease-modifying therapy.
Thank you. And that brings us to the end of our time. If any of you missed any part of this conference, it has been recorded, as I mentioned earlier, and it will be available through the MS Focus Facebook and YouTube channels. Just reply to your registration email for information on how to access those recordings or sign up for our newsletter to learn about upcoming events. Our next teleconference will be next Thursday, January 23rd at 3:00 p.m. Eastern. That day, Dr. Adam Chaffetz will present From the Front Desk to Your Doctor, Navigating Medical Care, and he's really good at explaining all of that. As you leave the conference today, a survey will appear on your screen. We really appreciate everyone that fills that out. We ask that you just take a minute to give us your feedback on the program and your suggestions for any future topics so we can actually provide you with the best programs possible and the ones that are most meaningful to you. Our sincere thanks to all of our attendees for your participation, and especially, of course, to Dr. Thrower for once again astounding us. And I know I use that each time, but you astound me for sure with your vast knowledge and your willingness to answer everyone's questions. Have a wonderful evening, everybody, and we hope to see you again soon.